Usually, when you think about emergency medicine, there is this expectation of instant, visible rescue. Like
Mhm.
a superhero swooping in,
Yeah.
you're having a severe allergic reaction, you get an EpiPen, and within moments, the swelling stops. It's really dramatic. But honestly, I don't think anything looks quite as much like a magic trick as a rescue inhaler.
Oh, absolutely. It's incredible to watch.
Right, because you're watching someone gasping for air, their chest is totally tight, and they're completely unable to pull oxygen into their lungs, but then they take one puff, and, within minutes they can breathe again. It functions almost like a biological crowbar that just pries open those clamped down airways.
It is incredibly dramatic to witness, for sure. And for the person actually experiencing that airway constriction, it is quite literally life-saving.
Mm.
The sheer effectiveness of that biological crowbar is, without a doubt, a massive triumph of modern pharmacology.
Right, it's a miracle drug.
Well, sort of. But the fascinating reality we find in the medical history is that this exact effectiveness actually blinded the medical community to a much deeper problem for decades.
And that really sets up our focus for you today. We are taking apart the molecule inside that rescue inhaler. Specifically, we're talking about beta-2 agonist bronchodilators.
Yes.
By looking at the pharmacological data and the historical sources for this deep dive, we are exploring not just how this drug manages to help millions of people breathe so quickly, but the dramatic and frankly, sometimes really tragic history behind how it was actually developed.
Right, and to start, the standard textbook definition of a beta-2 agonist bronchodilator sounds perfectly settled.
Yeah.
It is defined as a drug designed to bind to beta-2 adrenergic receptors, which are located on the smooth muscle lining your airways. The binding triggers a cellular reaction that relaxes the muscle, widens the bronchi, and allows air to flow freely.
So basically, muscle is tight, the drug relaxes the muscle, air goes in. On the surface, that seems like a totally complete solution to an asthma attack.
Right, it seems like one. And it is an accurate description of the mechanism, but it leaves out a really dangerous reality.
What's the catch?
Well, for a very long time, clinical medicine thought of these drugs strictly in terms of that single-function relaxing smooth muscle. The counterintuitive truth they totally missed is that these drugs do absolutely nothing to treat the underlying inflammation that actually causes the asthma in the first place.
Wait, really? So the drug is entirely focused on just fixing a symptom while totally ignoring the actual disease process driving it?
Exactly.
Yeah.
You can make a severely inflamed, angry airway feel perfectly fine to the patient for a few hours, while the actual inflammation quietly worsens underneath.
Oh, wow.
Yeah, that tension between treating the immediate symptom and ignoring the root disease is basically a recurring theme in the history of respiratory medicine.
I definitely want to get into those historical consequences, but I think to really appreciate how this drug masked the disease, we first need to understand the biological magic trick itself.
Sure.
Like, how does this molecule actually pull off this rapid rescue act? What is physically happening inside the cells of your lungs when you take that puff?
Well, the cellular chain reaction is actually a really elegant piece of biology. The drug enters the lung and physically binds to a specific receptor on the surface of the smooth muscle cell, the beta-2 receptor.
Okay.
And this receptor belongs to a family called G-protein coupled receptors. They basically sit right across the cell membrane, acting like a communication bridge between the outside of the cell and the inside.
Oh, I see. So the drug never actually enters the cell itself. It just docks on the outside and rings the doorbell.
Yeah, ringing the doorbell is a really good way to look at it. Specifically, it activates a stimulatory G protein, often called Gs, located on the inside of the cell membrane.
Gotcha.
When the drug binds to the receptor changes shape, which wakes up this Gs protein. The Gs protein then detaches and slides along the inside of the cell membrane until it bumps into and activates an enzyme called adenyl cyclase.
It's like a microscopic domino effect. The drug hits the receptor wakes up the protein activates the enzyme.
Precisely. And that enzyme, adenyl cyclase, has a very specific job. It grabs a molecule called ATP, which you might recognize as the basic energy currency of all human cells, and it converts that ATP into a messenger molecule called cyclic AMP, or CAN-MP.
Okay, so we've made a messenger, but what is the messenger actually telling the cell to do?
Well, rising levels of CAMP activate another a major player protein, kinase A, or PKA. PKA is an enzyme that goes around the cell phosphorylating, which basically means turning on and off several different protein targets.
Right.
But the ultimate checkmate move of this entire signaling cascade is how PKA alters the cell's calcium handling. It actively pumps calcium out of the cell and hides it away in internal storage. So it drastically lowers the amount of free intracellular calcium.
Wait, calcium. I know calcium is crucial for like bone density and nerve signaling, but in the context of smooth muscle, it's acting as the trigger for contraction, right?
Yes, exactly. For any muscle to contract, including the smooth muscle wrapping around your airways, it relies on a mechanical system of protein filaments called actin and myosin.
Uh-huh.
Think of them as tiny hands pulling on ropes to shorten the muscle and clamp the airway shut. But those hands can only grab the ropes if there is a high enough concentration of calcium present to expose the binding sites.
Oh, I get it now. So if calcium is essentially the fuel for the muscle contraction engine, this drug, through that whole G-protein domino cascade, basically cuts the fuel line. It removes the calcium, which just forces the muscle to let go.
That's spot on. Without calcium, the actin-myosin contraction machinery simply cannot physically engage. The smooth muscle has literally no choice but to relax. The grip loosens, the airway physically widens, and the patient can suddenly pull oxygen back into their lungs.
Okay, so receptor, G-protein, adenyl cyclase, CAM-PPPKA, drop the calcium, open the airway. I mean, it is a brilliant, highly targeted system.
It really is.
But the sources highlight that earlier generations of asthma sufferers didn't actually have this perfectly targeted fuel line cutter. We didn't just stumble upon this perfect molecule in nature.
No, not at all. The modern rescue inhaler was engineered out of necessity, and unfortunately, out of tragedy. If you look back at the early days of modern medicine, the very first treatment of this kind was epinephrine adrenaline.
Oh, wow.
Yeah, it was isolated in 1901 and soon used as an injection or like an inhaled mist for severe asthma attacks.
Well, adrenaline definitely opens your airways. That's, the body's natural fight or flight response.
It does open the airways, but epinephrine is a massive blunt instrument. It doesn't just target the lungs, it hits every single adrenergic receptor in your body simultaneously.
Oh, yikes.
Yeah, so your airways open, but your blood vessels constrict, your blood pressure spikes dangerously high, your heart starts racing out of your chest, and you get severe tremors.
Wait, if doctors knew epinephrine was sending a patient's cardiovascular system into absolute overdrive, why would they use it on someone who is already in a state of panic because they can't breathe? That sounds incredibly dangerous.
I mean, they kept using it because it was quite literally the only pharmacological tool they had to stop an asthma attack.
Mm-hmm.
The fundamental concept that you could somehow separate the lung opening effect from the heart racing effect didn't even exist yet.
They were just flying blind.
Exactly. The medical field needed a radical conceptual shift to understand how the body's communication system actually worked. And that shift finally arrived in 1948, thanks to a pharmacologist named Raymond Alquist.
What did Elquist figure out that everyone else was missing?
Well, until then, scientists basically assumed receptors were just a single lock and key system. Adrenaline was the key, and it turned every lock in the body the exact same way.
Yeah.
But Alquist proposed that these adrenergic receptors actually came in two distinct flavors, which he named alpha and beta. It was a revolutionary way to classify how different tissues receive chemical signals. Adrenaline hit both, which is why it caused such chaotic effects.
Oh, so he realized there was more than one type of receptor responding to the same chemical.
Yes. And following that logic, in 1967, a physiologist named Robert Lands took the map a step further. He proved that the beta family of receptors could be split again into two highly distinct types based on where they lived in the body.
Okay, so beta-1 and beta-2.
Exactly. The receptors predominantly driving the heart's pacemaker cells, he called beta-1, and the receptors predominantly controlling the relaxation of smooth muscle in the lungs, he called beta-2.
That is a massive breakthrough. Because if you know the heart is controlled by beta-1 receptors and the lungs are controlled by beta-2 receptors, you finally have the blueprint to build a drug that only goes to the lungs and completely leaves the heart alone.
Yes, this specific cellular distinction made the idea of a selective bronchodilator possible. The sheer urgency to actually invent that drug, however, came from a massive public health crisis occurring in the United Kingdom during the 1960s.
Yeah, the sources mention a really alarming spike in mortality related to a drug called isoprenaline.
Right. Isoprenaline was a highly popular inhaler introduced in the 1960s. It was a powerful bronchodilator, but it was non-selective.
Meaning it hit both receptors.
Exactly. It stimulated beta-1 receptors in the heart just as fiercely as it stimulated beta-2 receptors in the lungs. Furthermore, pharmaceutical companies were packaging this drug in these new, high-dose, pressurized aerosol inhalers.
So a patient having an asthma attack takes a deep breath of this aerosol, and they're basically taking a massive direct hit of stimulation right to their heart's pacemaker cells.
It was disastrous. Epidemiologists began tracking a sharp, terrifying rise in asthma-related deaths in the UK, Australia, and New Zealand between 1961 and 1967. The clinical evidence pointed directly to cardiotoxicity. Patients were suffering from deadly arrhythmias driven by that intense beta-1 stimulation. And the danger was really compounded because the inhalers were so convenient, patients were relying on them at home instead of actually seeking emergency medical care.
So they were dying from cardiovascular events triggered by the very medicine they were using to save their lungs.
Yeah, it served as a massive wake-up call for the entire medical establishment. In direct response to the isoprenolone tragedy, a chemist named Sir David Jack set out to physically alter the molecule.
Okay.
His team at Allen and Hanbury's, which later became GlaxoSmithKline, tweaked the chemical structure of these bronchodilators to make them fit perfectly into the beta-2 receptor while physically bouncing off the beta-1 receptor.
And that's the breakthrough.
Yep. The result was a molecule called salbutamol, known in the U.S. as albuterol. It was patented in 1966 and launched in 1969.
And, over 50 years later, albuterol remains the most prescribed asthma medication on the entire planet. It is the quintessential rescue inhaler.
It stands as a landmark achievement in rational drug design. They identified the specific molecular flaw causing the cardiac deaths, mapped the receptor landscape, and engineered a precise chemical solution.
But as brilliant as that engineering was, the sources reveal a massive secondary complication. Salbutamol solved the beta-1 heart problem, but that very success accidentally paved the way for an entirely new disaster.
That's the tragic irony here. The danger of non-selectivity in cardiac arrhythmias was effectively mitigated, but the danger of ignoring the root disease was just beginning.
Right.
Because albuterol and subsequent selective drugs were so incredibly effective at forcing the airway open, they masked the underlying disease pathology better than any drug before them.
This loops right back to the central tension we discussed earlier, treating the symptom versus treating the inflammation. The biological crowbar works so well that everyone ignores why the door was actually stuck in the first place.
Exactly. To see how deadly that illusion can be, we have to look at the New Zealand formoterol epidemic from 1976 to 1989.
Formoterol.
Yeah, it was another highly selective beta-2 agonist, but it was marketed at a relatively high per-puff dose. Shortly after it was introduced, New Zealand experienced a distinct, massive spike in asthma mortality that wasn't happening in other countries.
Wait, if formoterol was selective for beta-2, it wasn't causing the heart arrhythmias like the older drugs, right? So why were patients dying?
Epidemiologists spent years trying to unravel it. They eventually realized the drug wasn't inherently toxic to the heart. The problem was a behavioral and physiological trap.
What do you mean?
Well, because formoterol was such a fast-acting, high-dose bronchodilator, it could pry open an airway even when the lungs were severely, dangerously inflamed and swollen.
Okay, I think I get it. Relying entirely on a beta-2 agonist for asthma is basically like taking heavy painkillers for a broken bone and then going for a jog without ever putting the leg in a cast. You feel totally fine, you have full mobility, while the actual structural damage just gets worse and worse with every step.
That analogy mirrors the clinical reality perfectly. Patients would experience a severe asthma attack, take a puff of formoterol, and feel immediate relief. Their airway opened, but the cellular inflammation was raging unchecked.
So it just kept building up.
Right. Hours later, the airway would clank down again, often even harder because the swelling had increased. They'd take another puff. They kept self-treating with this powerful symptom reliever at home, right up until the inflammation caused a physical obstruction like mucus plugging and extreme swelling, so severe that literally no amount of smooth muscle relaxation could open it. They simply suffocated.
That is terrifying. The drug worked so well it convinced them they were completely safe, right up until the point of no return.
After formoterol was heavily restricted and withdrawn from the New Zealand market in 1990, asthma mortality plummeted back to baseline. You would think the medical community would have fully absorbed the lesson about masking inflammation.
But they didn't.
Not entirely. The point had to be proven again on an even larger scale. This brings us to a major paradigm shift in respiratory medicine, the 2006 SMART trial.
So what were researchers looking for in the SMART trial, and what kind of drug were they testing this time?
They were studying a drug called salmeterol. Salmeterol is a long-acting beta-2 agonist, or a LABA. Unlike albuterol, which wears off in a few hours, salmeterol has this long lipophilic tail in its chemical structure.
Oh, okay. What does that do?
It allows it to anchor itself into the cell membrane of the smooth muscle and continually stimulate the beta-2 receptor, keeping the airway open for 12 hours or more.
Oh, wow. A 12-hour crowbar.
Exactly. The SMART trial was a massive post-marketing surveillance study in the United States, tracking around 26,000 patients. And the results were so alarming that the trial had to be abruptly halted.
Wait, why did they stop it?
The data revealed a statistically significant increase in asthma-related deaths and life-threatening respiratory events in the salmeterol group compared to the patients taking a placebo. Crucially, the researchers found that this catastrophic risk was highly concentrated among patients who were taking the LABA by itself as a monotherapy, without also taking an inhaled corticosteroid, which, is the medication that actually suppresses the immune inflammation.
Ah, there it is.
The data also showed it disproportionately affected Black patients in the study, likely due to compounding factors in healthcare access and prescribing patterns.
So they were caught in the exact same trap as the formoterol patients, just on a much longer timeline. By taking the long-acting painkiller without the cast, they were keeping the airway forcibly propped open all day long. The patient feels fine, but the silent inflammation is allowed to grow completely unchecked until it triggers a fatal event.
Exactly. The realization sent shockwaves through the FDA. In 2005, they issued a black box warning. And by 2010, the FDA mandated a strict rule long-acting beta agonists must absolutely never be prescribed as a monotherapy for asthma.
They have to be paired up.
Yes. They must always be paired with an inhaled corticosteroid. Once pharmaceutical companies started combining the bronchodilator and the anti-inflammatory into a single combination inhaler, subsequent massive clinical trials showed that the excess risk of death completely disappeared.
So the molecule itself wasn't toxic. Using it in total isolation to turn off the body's warning system was the fatal error.
Precisely. The accumulation of this data culminated in a massive global shift in how doctors treat asthma. In 2019, the Global Initiative for Asthma, known as GINA, radically updated their worldwide guidelines.
What changed?
For the first time in their history, they explicitly recommended against prescribing any short-acting beta agonist by itself. The era of the solo rescue inhaler for asthma was effectively over. Relief must always be paired with an anti-inflammatory.
That completely rewrites the standard of care. Now, the pharmacology of how these drugs interact with the lungs is fascinating, but our sources point out something truly bizarre when we look at the rest of the human body.
Yes, the off-target effects.
Right, because these drugs were engineered specifically for the lungs, but smooth muscle isn't a tissue exclusive to the respiratory system. It exists all over the place.
That's the problem. You cannot easily tell a drug to stay localized just in the lungs. Once a beta-2 agonist enters the bloodstream, it goes looking for smooth muscle anywhere it can find it.
Right.
It lines your blood vessels, your digestive tract, and the uterus. Because of that systemic distribution, beta-2 agonists have caused some incredibly strange, off-target consequences in the real world.
Yeah, one of the most mind-blowing details in our sources is what happens at high systemic doses. If you take a beta-2 agonist in pill form or inject it, rather than just inhaling a tiny microgram puff, these drugs actually build muscle mass.
It sounds wild, but yes. They possess potent anabolic effects at high systemic concentrations. The beta-2 receptors in skeletal muscle tissue get stimulated, which fundamentally alters the body's metabolism. It repartitions nutrients, actively shifting the body toward building lean muscle mass and away from storing adipose fat tissue.
Which naturally means athletes figured this out, and the drugs are heavily regulated in sports. The World Anti-Doping Agency bans most beta-2 agonists above certain inhaled thresholds. And honestly, this metabolic quirk led to one of the most absurd sports medicine scandals I have ever heard of.
Oh, the 2011 incident?
Yes. In 2011, the Mexican national soccer team ran into a massive issue right before a tournament.
Right. 5 players on the team suddenly tested positive for clenbuterol, which is an incredibly powerful, long-acting beta-2 agonist. They were facing immediate suspension right before the CONCACAF Gold Cup.
But the investigation proved they weren't actually doping.
No, they weren't. The investigators discovered a fascinating, albeit bizarre, supply chain issue. Because of those profound muscle-building and fat-burning properties, clenbuterol had been used illegally in regional livestock farming to rapidly bulk up cattle before slaughter.
Oh my gosh.
Yeah, the soccer players tested positive because they had unknowingly eaten contaminated meat at a training camp in Mexico.
A lung drug, illegally repurposed to bulk up cows, accidentally disqualifies international soccer players. The interconnectedness of biology and pharmacology never ceases to amaze me.
It is quite a story.
But the systemic effects aren't just trivia, right? They have serious medical implications. You mentioned earlier that the uterus is made of smooth muscle.
This is where off-target effects get clinically serious. For decades, a specific beta-2 agonist called terbutaline was widely used off-label by obstetricians as a tocolytic, which is a drug to halt premature labor.
Oh, because if the drug can relax the smooth muscle in the airway to stop an asthma attack, it can relax the smooth muscle of the uterus to stop contractions.
The physiological logic is completely sound, but again, you have to consider the risk of high systemic doses. To stop labor, they were giving terbutaline continuously via IV or injection.
That's a lot of the drug.
It is. In 2011, the FDA was forced to issue a severe warning against using injectable terbutaline for longer than 48-72 hours for preterm labor. The continuous, high-level beta stimulation was causing severe maternal cardiac events, arrhythmias, and even maternal death.
Wait, hold on. If the whole point of Sir David Jack engineering albuterol and these modern drugs in the 1960s was to make them beta-2 selective specifically to protect the heart, why does a high dose still trigger cardiac events? Why does my own heart sometimes race when I take my asthma inhaler?
Oh, that highlights a fundamental, unbreakable rule of pharmacology. Selectivity is relative. It is never absolute.
Okay, what does that mean?
It is a preference, not a perfect shield. At normal, low-inhaled doses, a drug like albuterol mostly sticks to the beta-2 receptors in the lungs. But as you increase the dose, the drug floods the system.
And it overflows.
Exactly. It loses that preference and starts spilling over, binding to the beta-1 receptors in the heart. Furthermore, the human heart isn't 100% beta-1. It naturally has a small population of beta-2 receptors as well. You heavily diminish the cardiac risk with a selective drug, but you can never entirely eliminate it.
That really shatters a common misconception. I think a lot of patients just assume, hey, if I still can't breathe, I should just keep taking more puffs of my inhaler until my airway finally opens.
And that is a very dangerous assumption. Beta-2 agonists have a strict pharmacological ceiling. Once all the beta-2 receptors in your airway smooth muscle are saturated and activated, taking 10 more puffs will not open your airway 1 millimeter further.
So the extra medication just enters the bloodstream and wreaks havoc.
Yes. The excess drug spills over systemically, triggering those side effects. You develop severe tremors as it hits skeletal muscle, tachycardia as it hits the heart, and crucially, hypokalemia, which is a dangerous drop in blood potassium levels.
Why does potassium drop?
Intense beta-2 stimulation actively drives the sodium-potassium pumps in your cell membranes into overdrive, pulling potassium out of your bloodstream and hiding it inside your cells.
Which brings up an incredible medical plot twist in the sources regarding that exact potassium drop. Emergency room doctors actually weaponize that specific side effect to save lives in a totally different context.
They absolutely do. Emergency medicine is all about using the tools at hand. If a patient comes into the ER with hyperkalemia, which is a dangerously high level of potassium in the blood that can literally stop the emergent, the heart doctors need to lower that potassium immediately.
Right.
One of the first things they will do is administer a massive dose of nebulized albuterol.
That is wild. They use a massive dose of an asthma-lung drug to intentionally trigger a side effect to fix a blood potassium emergency.
This is pretty resourceful.
Okay, so given everything we've uncovered today, the masking of inflammation, the off-target effects in the muscles and uterus, the loss of selectivity at high doses, how is the medical community actually managing these tools today?
Well, the modern approach is heavily focused on what are called MART, or SMART regimens.
Mars.
Yes. This stands for maintenance and reliever therapy. Instead of handing a patient two separate inhalers, one for daily control or maintenance and one for sudden emergencies, they combine the strategy into a single device.
Ah, so you physically force the painkiller and the cast to be taken together.
Precisely. They utilize a very specific pharmacological combination. They pair an inhaled corticosteroid with a drug called formoterol.
What's special about formoterol?
Formoterol is unique. It is a long-acting beta agonist, so it keeps the airway open for 12 hours, but it has a chemical structure that allows it to act on the receptor just as fast as albuterol.
So it basically serves as the rapid rescue drug and the long-term maintenance drug simultaneously.
Exactly. It deliberately blurs the old, dangerous lines. By using this single combination inhaler for both daily maintenance and as-needed relief, every single time the patient reaches for the device to relieve a symptom, they're automatically receiving a dose of anti-inflammatory medication to treat the root cause of the disease.
That is such a brilliant way to correct the behavioral trap we talked about earlier. And it's worth noting, beta-2 agonists aren't the only way to open an airway. In diseases like COPD, chronic obstructive pulmonary disease, the sources mention doctors often pair them with anticholinergics.
Yeah, anticholinergics are a highly complementary tool. Instead of stimulating a receptor to cause relaxation, they block a different neurotransmitter called acetylcholine, which normally tells the airway to constrict.
So you attack the bronchospasm from two entirely different biochemical pathways.
Exactly. Furthermore, a quick puff of a beta-2 agonist is even used in the clinic as a diagnostic tool called a reversibility test. If a patient's breathing dramatically improves after taking a short-acting beta agonist, it heavily indicates they have asthma rather than COPD.
It's amazing how the pharmacology of these drugs doesn't just dictate individual patient care. It actually moves global population-level mortality statistics.
It really does. Asthma affects hundreds and millions of people globally. Because of the data we've explored today, the medical community's perspective on inhaler use has completely inverted.
How so?
Well, historically, using your rescue inhaler frequently was just seen as a sign of having severe asthma. Today, if a patient is going through 3 or more short-acting rescue canisters a year, it is a massive clinical red flag.
Right, because it tells the doctor that the underlying inflammation is raging out of control, and the patient is basically standing on the edge of a severe, life-threatening exacerbation. Overuse of a reliever is now a metric of extreme danger, not a sign of a well-managed patient.
Exactly. It is a remarkable narrative of how our understanding of a single molecular pathway evolves and how rigorously analyzing clinical failures reshapes the entire landscape of global medicine.
Absolutely. Well, to pull all of these threads together for you listening, number one, beta-2 agonists relax airway smooth muscle by triggering a cellular cascade that drops calcium levels, but they are entirely blind to underlying inflammation. Number two, selective drugs like albuterol were chemically engineered in the 1960s to avoid the catastrophic heart toxicity seen with early non-selective drugs. Number three, relying on these drugs without a concurrent anti-inflammatory essentially masks the disease and actively raises the risk of death, a realization that completely rewrote global asthma guidelines. And finally, selectivity is a preference, not a guarantee. Take too much, and the drug will still find your heart.
A perfect summary.
We've seen how designing a brilliant, life-saving molecule to treat a visible symptom ended up tricking both patients and doctors into ignoring the underlying disease for decades. It really makes you wonder what other highly effective symptom-relieving drugs sitting in our medicine cabinets right now are secretly letting a fire burn in the background simply because they are so incredibly good at turning off the smoke alarm.